as well as other endothelial abnormalities in the mother that can lead to hypertension, kidney damage, and proteinuria, as well as other complications, including liver dysfunction, and in some cases, cerebral edema and stroke. And then if we looked at the actual placenta, you can in some cases in preeclampsia see an infarction of the arteries in the placenta, which of course reminds us of infarction in the heart. And so there's certainly vascular connections. And then in gestational hypertension, which is sort of a milder form of pregnancy-induced hypertension, you can actually see hypertrophy of the media of the artery in the decidua, in the maternal side of the placenta, which is really similar to what you can see in essential hypertension, actually. And so these types of pathologic changes are markers for hypertension and endothelial dysfunction in the mother. And they might be some pathways that connect the hypertension in pregnancy to later cardiovascular disease in the mother. So who gets preeclampsia? How can we identify these women? Well, this is sort of a slide with lots of things on it, but I'll go through it because I think it's important. So women who've had a previous history of preeclampsia are at risk if you've had a multiple gestation, so a twin or a triplet, etc. pregnancy. History of chronic hypertension, diabetes, kidney disease or organ transplantation. And also if it's your first pregnancy, you're at higher risk for some reason. We don't know exactly why. Part of it could be that you're counseled not to have another one, but that is a true association that's been shown over and over. Obesity, age over 35 or under 20 years of age, if you have a family history of the problem. Polycystic ovarian syndrome, if you have a rheumatologic disease or autoimmune disorder. If you've had in vitro fertilization, sickle cell disease, or if you're African American, those are risk factors. Those are important to know because of a new guideline. That is that low-dose aspirin is now recommended for women at risk for developing preeclampsia, so at a higher moderate risk from week 12 through week 36 to 37. So we actually do give our pregnant women aspirin now to prevent preeclampsia. This shows the association between preeclampsia and later cardiovascular disease. It's an older slide from 2007, but the newer updated meta-analyses look pretty similar, and I like this figure, so I put it in. So if you look at the collection of studies done relating preeclampsia to cardiovascular disease mortality in women, the relative risk, if you pool everything together, is a little bit over 2. So women have a 2-fold excess risk of developing cardiovascular disease later in life. They have had preeclampsia. There are other pregnancy complications which I will just touch upon very briefly. Gestational diabetes is one of them. This occurs now in about 8% of pregnancies in the United States. It's certainly a very expensive issue, and there are over 220,000 cases annually. An important fact that I think gets lost is that women with gestational diabetes are four times more likely to have diabetes than women who don't have it, and it's the strongest risk factor in several studies for developing diabetes in women. So it's an important thing to ask about. This is data from Canada, and it just shows that if you have diabetes, you are more likely to develop cardiovascular disease than if you don't. However, in this study, once they adjusted for subsequent diabetes, the hazard ratio wasn't significant. So a lot of the risk is mediated through subsequent type 2 diabetes. This is more recent data from the Nurses' Health Study, and I'm just pointing this out mainly. It's sort of similar associations, but what they did was that they actually adjusted models that looked at the association between gestational diabetes and cardiovascular disease for lifestyle factors, so healthy eating. And they actually found that you could come from like a risk of 7 in an age-adjusted model and 5 in a multivariable adjusted model to 4.27. So you can attenuate your risk with a healthier lifestyle, at least a little bit. I'm not going to talk about this too much, but I wanted to introduce you to the concept that having a small baby is a risk for maternal cardiovascular disease later in life, and we think it's a vascular phenomenon that underlies this. So this is an umbilical artery Doppler from a woman who's pregnant and who has a small baby. And there's actually an absent end diastolic flow in this Doppler signal of that artery. In the uterine artery of the mother, there's also lower blood flow and to the placenta, and that's a measurable thing. So we believe that the fetal growth restriction that results in a small baby, it's a sign that the mother might have a vascular abnormality herself, and that later in life might manifest in cardiovascular disease. This is data from our group, also from the Swedish population registers, that showed that if you had a baby that was born very small and very preterm, then that mother had almost a threefold excess risk of cardiovascular disease compared to the woman who delivered a term baby who was a normal size. So how do we summarize all this? Well, there are all those physiologic changes that I went over to begin with that happen during a normal pregnancy. And if there are abnormalities in those or accentuations in some of those, then you can develop one of these pregnancy complications listed here. Those probably put a woman at risk for having established cardiovascular risk factors, and those are the majority of the pathway that leads to cardiovascular disease. So a lot of it is probably preventable, these sort of later issues that happen here in green. But there are probably some novel mechanisms because there are independent associations of these adverse pregnancy outcomes with cardiovascular disease. So when we're connecting the dots, how much further forward are we worried about the risk of cardiovascular disease if a woman's had an adverse pregnancy outcome? Well, to answer this question, we looked at a data set called the Women's Health Initiative, which was essentially pushed forth by another champion cardiologist woman named Bernadine Healy, who is a cardiologist. She was a cardiologist. She was the first female director of the NHLBI and of the NIH, and she actually convinced Congress to fund a study called the Women's Health Initiative, which was a set of clinical trials and observational study that is still followed to this day and allowed us to ask the question, do adverse pregnancy outcomes relate to cardiovascular disease in postmenopausal or elderly women? And a couple years ago, we were able to deploy a survey into the population of mail it to the population of women who are still in the study. And this allowed for study of a large number of women, diverse race ethnicities, postmenopausal, and they had good risk factor in cardiovascular disease collection. So this was just some preliminary data from our look. This was work presented by Mark Sondergaard, who's a Danish medical student who came and worked with us for a year at AHAQ Corps just a couple of months ago, or just last month actually. And so we actually did show in 48,000 women who are still in the Women's Health Initiative study, their mean age is around 70. They had an association of gestational diabetes with later cardiovascular disease. So these are hazard ratios, these boxes, and the 95% confidence intervals are the lines, the horizontal lines. Low birth weight, gestational diabetes, preterm delivery, and hypertensive disorders were all still associated with cardiovascular disease, even after you adjusted for traditional risk factors. So we think there's still an association to think about, even many years later. So now with all that data, how can we prevent cardiovascular disease in women with reproductive factors or pregnancy complications? So which risk factors do we target, and how can we do that? So there are a couple things to ask. So which pregnancy factors, if you look at them all together, predict modifiable risk factors or accelerate their onset? And then can lifestyle modification be useful to delay the onset of hypertension? So in terms of that data, this isn't really the only study, but just an illustration. So we looked at this again in a population in Sweden where it's easy to study these things. I'm not going there just to go there, although it's quite a lovely place to visit when you do research. But they do have excellent data that can be harnessed and merged, and you can learn quite a bit from it. So we found that preeclampsia was associated with about a 7 millimeter increase in blood pressure among women women who were 40 years old. And a diastolic increase of about 4.7. Having a baby born very preterm at less than 32 weeks was associated with a higher blood pressure, systolic and diastolic. And then having a small baby, it was just very modestly associated with an increase in systolic blood pressure. So these things are important, but if you're looking at the most bang for your buck, probably preeclampsia if you're just going to focus on one thing. And then maybe very preterm delivery, at least in this data. And then if you look at hypertension, defined as 140/90, then preeclampsia in this population was associated with a 3-fold increase of that, and having very preterm delivery with about a 60% increase of hypertension, and small for gestational age, about 30% increase. But when you look at at sort of this issue of what to do about it and what studies can we turn to, where's the data that suggests that we can use lifestyle at least to modify blood pressure? Well, this is a systematic review by Nadia Jafar, one of our current cardiology fellows, and she compiled the data, studied, sort of had this umbrella of like thousands of studies she was looking at, and really only came up with these 4 studies that have targeted women in the postpartum setting. And there were 4 studies, no randomized clinical trials, and none targeting blood pressure alone. So we can't really go to the evidence to see if these things work. We kind of extrapolate a little bit, and then we hope that we can have a body of evidence that really directs us in this regard. A lot of the evidence that we use to base our lifestyle modification guidelines, like historical studies such as the DASH diet, they excluded women who were trying to get pregnant, who were breastfeeding, and so essentially, and who were pregnant. So it really excludes a lot of women of childbearing age. So I think this is an important area of research and evidence that we need. However, that hasn't stopped our experts from beginning to recommend thinking about these issues, which is good. I think this is a start. So this is the 2018 cholesterol practice guidelines, so the update. And there in small print, I'll read it for you, is that when you're thinking about a risk-enhancing factor, when you're trying to make a decision about prescribing a statin to somebody, you can consider these 2 reproductive factors. So one is a history of premature menopause before the age of 40. I didn't go over that data here. And history of a pregnancy-associated condition that increases later cardiovascular disease risk, such as preeclampsia. So it's a bit vague. I wish that they would study the evidence a bit more, because now there's a body of evidence. So I think we really need to start to think about this systematically, which, among all those things I mentioned, let's look at them head to head and see which ones matter the most, and then base our evidence on that. So that's my hope for the next iteration of the guidelines. We'll see. So I'm going to finish up soon, but I just wanted to highlight this issue that is now coming up, that can we use this postpartum period to capture these women and begin to modify their risk? Well, routine postpartum visits are at 6 weeks. 40% of mothers, unfortunately, in many healthcare systems don't attend the postpartum visit. And about 30% see their OBGYNs annually. Only 19% of women age 18 to 44 go to a general or family practitioner. So the question really is, should we have a cardiovascular disease risk factor modification visit at either 6 months or 1 year postpartum for women with a cardiovascular disease-related pregnancy outcome for enhanced continuity? And the ACOG came out with this statement. This is James Martin, who's the chair of their Pregnancy Heart Task Force this year. Perhaps it reflects our need to change payment models so doctors and patients recognize the importance of coming back. The end of pregnancy is the beginning of the rest of their life. So I think at least our experts, both on the OB side and the cardiology side, are starting to recognize this, but we need to make sure it filters out to everybody else as well. So these were the key points discussed. Hopefully I mentioned to you why the topic's important, how adverse pregnancy outcomes are related to cardiovascular disease. I highlighted some changing clinical practice guidelines, and then also hopefully gave some ideas for health system changes that could improve outcomes, including targeting reproductive and pregnancy history for cardiovascular disease risk stratification. Can we get it into our SMART sets in EPIC? That's something I've been working on at my own institution. So it's just a really quick history. It doesn't need to be elaborate. Can we change the timing of postpartum screening, or can we do remote screening or remote education to these women that are busy taking care of their babies? And then integrated OB and cardiology clinics are important for high-risk women. So in conclusion, pregnancy is a cardiovascular disease stress test. Key reproductive and pregnancy complications can unmask a woman's predisposition to cardiovascular disease. Incorporate a reproductive and pregnancy history into a cardiovascular risk assessment, and carry out early and aggressive risk factor modification in women with CVD-related adverse pregnancy outcomes. And so those are my acknowledgments. Some of my collaborators at UCSF, the WHI, my funding sources are listed on this slide, and then although I don't have very many exciting disclosures, I have had 3 children and 3 pregnancies. So those are my disclosures. And then I have some resources which I can email out to you. Some of them are an infographic that is part of a handout today, but you can get an online version of it that I think is nice that the ACC puts out, the AHA lipid guidelines, as well as that maternal palliative care collaborative. Thank you so much for listening.
I was wondering, Neil Kahatsu, thanks very much, fascinating presentation. Are there any epidemiologic data on how women of childbearing age understand cardiovascular disease risk, and if not, even in your clinical experience, are women shocked, like, I didn't even think women got this, and then now you're telling me pregnancy relates? That seems like a double whammy shock to the system.
Yeah, that's a great question. There's some data on it. I probably couldn't quote it off the top of my head. I would say there's, I'd have to believe it's less than a quarter of women know that there's an increased risk. I think preeclampsia, that word's gotten out a little bit more. That's partially due to organizations such as preeclampsia.org that have really, sort of put the word out, if you will. Up until, I'd say, about 10 years ago, I think most women felt that if they were going to die of something, it would be breast cancer, and I think part of that is really the advocacy, the great advocacy around breast cancer awareness. So we're a little behind. I'm wearing this red dress pin, but how many people know that that's, go red for women? Our messaging isn't as strong, I think. So that's part of it. And then the pregnancy thing, I don't think that word has really gotten out there. My own colleagues, I'm working to get them, to get a pregnancy history. So it's hard. I think we have to do more work around
this. The graph showing the increased lifetime mortality after having preeclampsia or some of the other conditions is very worrisome, of course. How much of that do you think is it's unmasking pre-existing propensity to have that disease, and how much of it is causative? That the preeclampsia actually causes some of that?
That's such a great question, and it's been kind of a research interest of mine as well. We have some data that is preliminary but sort of in submission that suggests that women with an adverse pregnancy outcome, they have an accelerated trajectory of blood pressure as compared to women with a normal pregnancy. And you might say, well, it's kind of hard still to answer it, but what it shows is that regardless of your baseline blood pressure, for instance, your ending blood pressure is much higher than you think it should be. Those women have blood pressures that go like this postpartum, so from sort of first trimester to later, whereas the women with the normal pregnancies are like this. Their blood pressure starts out lower, but these aren't parallel lines. These are splaying. So it might be that the pregnancy per se and experiencing that pregnancy complication can activate biologic pathways that worsen and accelerate that trajectory, the cardiometabolic trajectory. That's like my personal feeling is that is happening, but I can't prove it yet. I don't even know how.
Thank you.
So thanks, that's great. We've been, of course, trying to get this message out, and my boss Doris will be telling you more about that. But so I didn't realize that ACOG had finally endorsed some of those risk factors. And was the 2019 the first time that they had done that? Or was it previous renditions?
So ACOG's been doing it, but the AHA is now on board somewhat. Now I'm on the leadership committee for the Epi and Prevention Council at the national level. I'm not on the guideline writing committee for cholesterol. And within our community, at least the American Heart Association, that cholesterol guideline serves as sort of like the prevention guideline as well. And so it's sort of important to get recognized by that guideline, because then it sort of filters down to everything else. I think there's a little bit of recognition, but I talked to the authors and they said, well, we just put those in because those are the ones we knew about. So I don't think that people have looked at it very systematically yet. And it's my hope that, being the nerdy scientist I am, that our data will be exciting enough to get picked up. But some of it's advocacy and just making sure you are at the table or presenting the information.
Well, and that's what we found was a bit of a challenge. The AHA's 2011 gave some guidelines that never got incorporated into the other national guidelines, and so there was always that being on the peripheral side of being able to really integrate that into the strategies for education.
Yeah, that's a great point. So we probably have some work to do. But ACOG, this latest one is literally just released last week, and it was brought to my attention by Dr. Ivy. So it's a start.
Hi, can you hear me? Is there any work being done around capturing? You mentioned 40% of patients not keeping their postpartum appointments. Is there any work around that, especially for those moms that tend to develop preeclampsia after they have a baby?
Yeah, that's a great question. And postpartum preeclampsia can be particularly challenging because the women aren't in the healthcare system. They might not even know they're at risk. There are guidelines, and I don't know how much they're being followed. That, well, for the other case, so preeclampsia during pregnancy, they're supposed to have a visit with either a nurse practitioner or a doctor within 72 hours of their discharge. And most of the time, we want them to be sent home with a blood pressure cuff, if they can, to be measuring their blood pressure when they go home. And in terms of the postpartum preeclampsia, that's really the scariest one, that we don't really have a good sort of prevention metric for at this point. But I think, just to kind of finish, it's my hope that we can leverage, I don't think we can leverage digital technology for every single thing in healthcare, but I think this is an area where we might have an opportunity to use remote blood pressure tracking, sort of home cuffs, and maybe even sort of remote interfacing with the doctor or the healthcare practitioner to take better care of patients in a low-touch way. The moms are so busy, so you don't want to interrupt that childbearing either.
I think this will be our last question for this speaker, unless we can just hold the other questions till the general discussion period.
Hello, good afternoon. I'm Marsha Bennett, Captain Bennett from the Grad Medical Center. Quick question I had for you. The women that have these adverse pregnancy outcomes and you start them on aspirin, 100 to 150 milligrams, how long are they on that for?
Well, so that's a great question. The aspirin's actually during pregnancy for women at risk for developing preeclampsia, but what we don't have great data on is if aspirin helps us postpartum to prevent cardiovascular disease. Now, aspirin is falling out of favor generally for primary prevention. There may be some argument around that, but I think that at least most of the data that have come out recently suggests that we really shouldn't be giving it to people for primary prevention. And it's sort of nuanced, but some people think that's because everybody's on a statin now too. So if someone's on a statin, it sort of takes care of most of the risk, and so aspirin gives you like a really marginal benefit now, but it will increase your bleeding risk. But for women in the postpartum setting, is their 10-year risk going to be high enough that we even give them a statin? And does aspirin have a role? We don't have any data yet for that, but I'm hoping that is an area that we study.
Thank you.
epidemiology of women's cardiovascular health to hearing the perspective of a senior administrator here in Northern California. She is the Vice President for all things cardiology and all things vascular for UPD Health. This is 6 large medical centers here. She has over 25 years experience of getting together all the resources and personnel and everything we need to be able to implement the changes to make a difference. Doris has served on the board of directors for the American Heart Association here in Sacramento, and as well as the American College of Cardiology Administrators. So we are very lucky today to get to hear her perspectives as a professional administrator of these programs, and then also her family story on this Mother's Day edition for cardiovascular health for women.
Thank you very much. I'm impressed that you memorized all of that. So I am very pleased to speak today on this particular topic, and it is in honor of Mother's Day. So Joyce Higley, who is my senior director of our Heart and Vascular Institute, we've been working on this women's initiative for many years, and she prior to me for many years in the Sacramento area. And when the guidelines were developed and published in 2011, we had some women in our community that said, you guys need to do a better job about educating. So that's what I'm going to talk about today, is the educational program, kind of taking that science that you're in the lab and doing all of these things, and then taking that and how do we educate the community, how do we educate physicians, and how do we make it fun? Because when you look at the breast cancer movement, you know, really, although it's a terrible disease, they kind of made it fun with some of their slogans like "Save the Tatas." I mean, everybody pays attention to that. So we really have to think about how do we make being cardiac healthy, heart healthy, fun. So my Mother's Day story is when I was a little girl, my mom had this book. And it's the Pictorial Medical Guide by 40 Specialists. And it's all about women's health. So as we started on this journey of women's heart health, I thought, oh, what does this book say in 1953? Can anybody guess? So the question of women and heart disease: do women have special circulatory disturbances? So in 1953, it was a question that was posed out there. The answer is yes and no. The type, the picture of the disease is not different from that of the man's heart ailments, but certain symptoms and diseases originate frequently from distinct alterations in the female organs. Well, you know what? That might be true. We don't know. And then the next section is the sex organs may be at fault. So, obviously, there you go. So I just found that in there as I was perusing this book. But the other thing, I did look at a historical perspective as well, is this is under the section on chest pain. I thought this was interesting. Set the patient at ease. Remember that sensations in the heart regions are always frightening. Therefore, give the patient no sign that you are shocked. Keep smiling. Show him that he may not be in real danger, because it really wasn't recognized that women obviously had heart disease and heart attacks back in 1953. The patient who loses the hope that he can survive an attack or overcome the heart condition loses half the chance he has. It is therefore up to you, the woman, to strengthen his will to live and give him hope. 40 medical specialists said this. Pain, and this is how it was treated. Pain in the chest without other symptoms may be overcome by a few drops of spirits of ammonia. If the pain is agonizing, the face pale or bluish, and covered with cold sweat, give repeatedly small amounts of straight brandy or whiskey. We all know that's a vasodilator, right? There's science there. Put the patient in a comfortable position. Apply repeatedly very hot application